Good afternoon, everyone. Welcome to this very special briefing. We've got some very interesting content planned for you today. It's a special briefing on a very important topic, how we get people traveling safely across borders again. We've been speaking a lot in recent weeks about data and data-driven decision-making, and that, as you will recall, came out as part of the G20 discussion on their restart framework a few weeks ago. Today, what we'd like to do is to present just what that might look like. And so we have some demonstrations of how data can be used to model scenarios in which travel can take place amid this, the ongoing pandemic. In terms of the timeline, this comes at an interesting time as we're just a week and a few days in advance of the G7, where we do expect governments to be discussing this topic because of its importance to how we reconnect the world safely. So to help us with this discussion, we've got a very excellent panel together. We've worked with Airbus and Boeing, who have been doing some modeling. So we've got their modeling experts, Elisabeth Masset, who's the air travel health assessment leader at Airbus, will be presenting. We have Lindsey Jones, who's the associate technical fellow at Boeing, responsible for modeling, so she'll also be presenting. We have our Director General, Willie Walsh, who will start us off with some commentary. And after we take a look at the models, we have Dr. David Heymann, a professor at the London School of Hygiene and Tropical Medicines. Dr. Heymann is also formerly of the World Health Organization, where during 2003, he led the emergency response to SARS. So a really excellent group of experts here to help us guide us through this discussion. And then once that's over, we will open it up to questions and answers. Those will take place through the chat function. And so in terms of other housekeeping notes, we are recording this for future reference, so you'll be able to review this after the presentations are done. And we will be distributing a release in the presentations at the end of today's event. So with that said, and without further ado, I'd like to turn it over to Willie Walsh for some opening comments. So Willie, over to you.
Thank you, Tony, and good afternoon or good morning. Thank you for joining us. So we're 15 months into the health pandemic and the airline industry remains in crisis. It is important to point out, however, that the crisis is no longer one and who were required to undertake PCR tests after their arrival. And the figures are quite startling. Of those who tested, only 2.2%, just over 8,000 people tested positive following their arrival in the UK. If we eliminate red list countries, which accounted for 29% of the people traveling, but amounted to 53% of those who tested positive, the positivity rate drops to 1.46%. And if we look at EU countries only, excluding Ireland, because there is no restriction on people traveling from Ireland into the UK, you see that the rate drops to 1.35%. And three countries, Bulgaria, Poland, and Romania, who accounted for 30% of the people traveling into the UK, accounted for just over 60% of those who tested positive. So the data tells us we can do better. These universal restrictions on people are no longer necessary. I think the first step in this is that we've got to look at returning freedom to those who are fully vaccinated. And there's clear scientific evidence and growing scientific evidence to support that. And I'm just going to quote from a couple of recent studies. We saw the Robert Koch Institute, who concluded that vaccinated travellers are no longer significant in the spread of the disease. The European Centre for Disease Control and Prevention said the likelihood of an infected, vaccinated person transmitting the disease is currently assessed to be very low to low. The US CDC stated that with a 90% effective vaccine, pre-travel testing, post-travel testing, and 7-day self-quarantine provide minimal additional benefit. In Canada, the Canadian Testing and Screening Expert Advisory Panel recommends that vaccinated travellers do not need to be quarantined. And Public Health England study has concluded that 2 doses of the coronavirus vaccines are highly effective against COVID-19 variants of concern. So it's very clear to us that the risk we're facing today is significantly different to the risk that we had faced. And we cannot forget people who either haven't been vaccinated, can't be vaccinated, or have not yet had access to vaccinations, and that clearly accounts for many people around the world. We cannot deny them their right to freedom. And in this case, we believe that an effective testing and screening system could help to protect population, revive livelihoods, and boost economic growth. Now, Boeing and Airbus have done some significant modelling, which we're going to share with you today. The key here is data and being driven by that data. And we urge the G7, when they meet later on this month, to follow the lead of the G20, who called for a data-driven approach to this crisis. We need to be clear and honest with one another. There is no risk-free approach. The scientific evidence points to us having to live with this virus and to adapt and get on with our lives. And the evidence we have, supported by all of the research that has been done and complemented by the research you're going to see from Boeing and Airbus, supports our view that there is a safe way of reopening international travel. Thank you.
Great, thank you very much, Willie. Now I'd like to move to Airbus, and particularly Elisabeth Masset. Again, their head of travel health assessment. And Elisabeth, over to you to take us through the work that Airbus has been doing in this important topic.
Thank you. Happy to be here. So I'm sharing my screen. Okay. So we in Airbus, we developed a data-driven approach, a model, in order to show that air travel remains a very safe way of traveling, even when we take into account COVID-19. We are not health specialists, but we have years of experience in modeling aircraft safety and airport and cabin environment. We also have huge expertise in handling big data and risk assessments. And this is those expertise that we have used to develop the model that I will show. and because we believe in Airbus that air transport-related health risk can be addressed in a similar way as aircraft safety. As for aircraft safety, health risk can be reduced by layering and overlapping several preventive and protective measures. The tool that I will show you, the model I will show you, aims at supporting government stakeholders and regulatory bodies in their decision-making to reopen borders by providing them with quantitative risk assessments about the risk they are taking doing so, and also providing them with preventive and protective measures and measuring their efficiency to reduce the COVID-19 risk. But to do that, we have developed a true end-to-end model, as you will see, and also we're working with daily updated coronavirus data, which are coming from official epidemiological national sources. But let's go into more detail about the model. What are the risks that we are addressing? As I said, our model illustrates and is aimed at showing that traveling with aircraft in times of COVID-19, of a pandemic such as COVID-19, is always and remains very safe. As we are not health specialists, we have used health data provided by international or national health authorities like CDC, ECDC, or World Health Organization. But let's talk about the model itself. What we will show you are the real risks when traveling by air of getting the virus or transporting the virus from a departure country to a destination country. We take two factors into consideration where we talk about contamination: touching a contaminated surface or inhaling virus droplets emitted by another person. Another parameter that we take into account are the asymptomatic passengers, or hidden infectious passengers, as we call them. These are the passengers who are infected before the travel, but are asymptomatic, so don't know that they are infected, and are contagious. Those passengers have the risk to contaminate other passengers and also to transport the virus from a place A to a place B. This is one of the most important parameters of this model, because if we manage to sort out those passengers before they enter the air travel system, then they have no chance to contaminate other people or to translocate the virus from place A to place B. This is why we have implemented in the tool screening strategies or testing strategies, and we can, with these strategies, measure their efficiency to sort out those asymptomatic passengers either before they board the aircraft or at least before they enter the destination country. If we look more in detail into the model, what you see on that screen as the preventive measures we assume are enforced when traveling from an airport by air from an airport A to an airport B. Something you will notice is the air conditioning. This is something that Airbus talked already about because of the air in the cabin, which is renewed and filtered, renewed every 2 to 3 minutes with a downward wash effect. In fact, it is creative a preventive measure comparable to social distancing in public space. So what are we doing with the tool? For each steps of the air travel, starting from the entry door of the departure terminal till the exit gate of the arrival terminals, for all of the steps of the travel that you are seeing on the slide, we have defined a multi-layered series of multi-layered preventive measures, face-safe, as we do for aircraft safety, and we are assessing their efficiency to mitigate the risk versus COVID-19. But let's go to the tool itself to illustrate and to show you how it works and how it can support decision makers in making their decision to reopen border. So we have modeled more than 50 parameters which are accessible from the tool and some directly accessible from the front page that you see here, such as the flight time, the total time in the terminal, some options for checking and immigration passport control, if we allow or not the catering on board, and the testing strategies. So the testing strategies, these are the ones I have mentioned previously. We have defined 16 of them for the time being, but this is evolutive, and we are following the updates on the topic. But nonetheless, for the time being, we have defined 16 strategies from no testing till quarantine 14 days, assuming 100% compliance, which is very optimistic, as there are studies which show that it is not the case. And in between, we have different testing policy, like a PCR 3 days before travel, or antigen, so single testing policy, double testing policy, mixing tests before and after travel, and some tests, some protocols on arrival. For that, we have used a lot of data concerning the PCR test characteristics, antigen test characteristics, but also data concerning the incubation time with the COVID-19. So how does it work? I will show you 3 examples. The first one is a travel from a zone with a pandemic which has a medium to high rate, like in Europe today, so where the incidence 14 days is 107, which means that for 100,000 people in Europe today, for 2 weeks, we can expect 107 confirmed cases of COVID-19. So travel from that region to a destination country with a low incidence rate, so a low rate of pandemic. So I will take Iceland. Why do I take Iceland? Because this is a country where the authorities have put on the web a lot of data concerning their COVID situation, a lot of statistics, and we have used those data among other validation. Especially, we have used those data to validate the prediction that we are showing to you in the model. Also, Iceland is a country with a small size concerning the population, so it is interesting to see what happens in such a case. So, we have related the risk to the traffic, to the volume of the traffic. So, this is what you see here. So, I will take 50% of the traffic, which is more or less the situation today. So I will take 6 hours to go to Iceland, 3 hours in the terminal, and I will allow some catering. So the tool is being updated. You see that the incidence today, so this is updated, as I said, on a daily basis. The incidence in Iceland today, the 2 weeks incidence as calculated by ECDC, is 9, which means that in Iceland, for 100,000 people, we can expect for 2 weeks 9 confirmed infectious people with COVID-19. So if Iceland would then accept all the passengers, assuming 50% of the traffic compared to 2019, here is what would happen, according to our prediction. On this pie chart, you see on the gray part, or purple, depending on your screen, 9, which is the domestic incidence today of Iceland. I would assume 0% traffic. You would see that gray part will be the full circle, which means this is the incidence of Iceland, and if there would be no visitors coming from abroad, that incidence would stay as it is. Now, if Iceland would decide to accept to reopen their borders, assuming 50% of the traffic today, then what do we see? We see that, in fact, the incidence, which was 9 previously, would be increased by 8 to 9, so would double, because of the asymptomatic passengers which would come from Europe, where the pandemic rate is higher. So then, the decision makers opening the border like certainly to make some screening in order to sort out those asymptomatic passengers before they enter Iceland. So they could select some testing policy. So, for instance, PCR 3 days before travel. And then we see that it is improving the situation, but maybe not enough. In fact, what Iceland did they have selected PCR on arrival and another PCR test 5 days after arrival. And you see, doing so, then the risk is really mitigated. Then the local incidence would marginally increase by 0.3 compared to 9 if there would have been no screening policy. In the tool, we can compare different screening policies, so I can add some more. So I have the one that Iceland selected, and I can put quarantine, assuming, as I said, 100% compliance, which is optimistic. So this is the one that Iceland selected, and you see this is one of the best, which confirms the choice they made. And by the way, being optimistic, considering quarantine 2 weeks is 100% followed, which is not the case, you see that it is not the most efficient scenario. Now, let's take another example from traveling still from Europe, so medium to high risk zone, to a zone with low risk, but with a larger population than the one of Iceland. And let's see what happens. So I will take, for this Singapore, to go to Singapore, I need a bit more time. So 10 hours flight. Okay, and I start with no testing, and I will take 100% traffic versus 2019. So you have noticed that the incidence has been updated. So this is the 14-day incidence in Singapore. So I remind, it means that with today's situation in Singapore, for 100,000 persons in Singapore, we would have for 2 weeks 7 confirmed cases of COVID-19. So if I go to the pie chart as I did for Iceland, you see that if Singapore today would accept all the passengers from Europe without any testing, then they would increase their domestic incidence, which is 7, by 1.14. So lower than what Iceland would see as a risk, but still it can be considered as a too big risk by the authorities. So they might want to apply some testing or screening policy. So let's see if I apply PCR 3 days before travel. We see that already the risk has significantly reduced. It's only increasing the domestic incidence by 0.4. And if I decide to have a PCR before travel and at arrival, so without any quarantine, then we see that the risk is really marginal, 0.1. So you see that with a different situation, a different country, the answer is not the same, and it is really a case-to-case basis. Now let's take another example, my last example, from traveling still from Europe, so medium to high risk country, to the same level of pandemic zone, and I will take the USA. So remember that the incidence in Europe was slightly above 100. In the USA today, the 14-day incidence is 76, so a bit lower but comparable. Then if I take no testing, 100% traffic versus 2019, what do I see? I see that already, without any testing, the risk that the country would take allowing all the passengers from Europe traveling without any testing would marginally increase 0.4 their domestic incidence. Now, the authority, if they have the means with the tool, they would have the means with the tool to see if they cannot do something better, but not restricting too much the mobility of the passengers, like for instance, an antigen test on arrival. And then you see the risk that which is taken there is really marginal. So this to illustrate that depending on the case of the countries versus the pandemic, there are means with probabilities and a data-driven approach to define and to confirm about the best screening strategy policy to, I repeat, screening out the asymptomatic passengers before they enter the country. And the note is that what I show you here is conservative because we have deliberately not taken into account vaccination yet. So this is the risk that you see, assuming that none of the passengers would be vaccinated. So if I come back to the conclusion, if I go to the conclusion, so with this data-driven approach and this model that I've shown you, we show that traveling by air remains very safe because, in fact, the risk to be infected during the travel is really minimum. We also show that the risk of translocating or transporting the virus from a zone to another one of the world can really be mitigated to an acceptable level by choosing the right screening policy, the right screening strategy on a case-by-case basis. So to conclude, aviation today is capable of restricting virus translocation in collaboration with all aviation stakeholders. And when it is about safety, there is no competition anymore. So we have really worked across the industry all together to share data about this COVID-19 situation and mechanism and so on. And it's very good. I'm very happy to see that different approach, as we will see with Boeing, we are really reaching the same conclusions. But I will not disclose what my friends from Boeing will show you. So over to you, Lindsey. Thank you.
Okay, thanks very much, Elisabeth. And with that, we'll head over to the United States, and we ask Lindsey to take over and show us what Boeing's been working on. Lindsey, over to you.
Excellent. Thank you, Tony, and thank you, Elisabeth. Pull up my slides. Okay. So I'm going to tell you a little bit today about the Boeing Confident Travel Initiative passenger screening model. The Boeing Confident Travel Initiative began early in the COVID-19 pandemic, and the idea was to use a data-driven approach to evaluate the safety of the air travel system. So it started out looking at the airplane itself and then expanded to the entire journey, because in order for air travel to be safe, the whole journey has to be safe. So we're now focusing on, or the piece we're focusing on today is on protecting communities that are connected by air travel, and that is reducing the translocation of disease through international travel, through testing and screening. So, as I mentioned, we are using a data-driven, risk-based approach to reduce the risk of disease importation. And we have developed this model in order to aid policy decisions on passenger screening, testing, and quarantine, and to provide a comparison of the effectiveness of various strategies. And we've shown that screening and testing can reduce the risk of disease importation and can be used to minimize quarantine requirements for international travel. The model that we've developed is a simulation-based model where we simulate a group of COVID-19 infected travelers. And that simulation starts by creating an individual disease timeline for each infected traveler. And that disease timeline follows the general COVID-19 disease timeline shown in the top right graphic here on this slide, but there will be some variability. So each simulated passenger will have a unique disease timeline. From there, we look at the test performance as a function of that disease timeline. So we have considered two different types of tests, RT-PCR tests and rapid antigen test. And the graphic on the bottom right of this slide shows the probability of detection for each of those two types of tests at different times throughout the infection timeline. So this curve will be unique in our model for each simulated infected traveler, because each traveler will have their own unique disease timeline. The curves showing the probability of detection for each test will be slightly different for each infected traveler. So we use these simulated infected travelers and apply a screening or testing strategy and evaluate the performance of that screening and testing strategy in terms of detecting individuals who are infected and removing them from population or from contact with the population in the destination country. Additionally, we have calibrated our model using actual test data from travelers traveling to Iceland and Canada, two separate data sets from travel to Iceland and then one from Canada as well. In evaluating the results of our model, the primary metric that we use is prevalence, COVID-19 prevalence. So we assume that travelers will start out at a prevalence level that's representative of the origin country where they're starting their journey. And in this graphic here, that's represented by the top blue dotted line. Some of those infected travelers will be detected through testing and screening, and the prevalence will thereby be reduced by detecting those infections. The goal is to lower the prevalence among those passengers to a level that's below that of the destination country. So we start at the top blue dotted line, and the goal is to use testing and screening to get the prevalence down below the bottom blue dotted line, which represents the destination country prevalence. And for this reason, our model is most effective when looking at travel journeys from higher prevalence countries to lower prevalence countries, so we can see the decrease in prevalence and evaluate whether that's sufficient to get the prevalence below what is already there in the destination country. I'll show you some results next. And we start with looking at a typical 14-day quarantine that does not include testing. And with 100% compliance, if everyone is quarantining as they're supposed to be, the performance of a 14-day quarantine is quite good. You can see here that we started at that top blue dotted line for the origin prevalence, and we are now, after the 14-day quarantine with full compliance, well below the destination country prevalence for this example, below that blue bottom dotted line. And this is an example of travel from a high prevalence country to a medium prevalence country. However, one of the problems with quarantine is that often compliance can be quite low, especially for self-monitored quarantines. So as you can see in this bar that's highlighted right now, the performance of a 14-day quarantine with a low compliance, this is assuming a 25% compliance rate, is not very good at all. For this example, travel journey from a high prevalence to a medium prevalence country, this low compliance quarantine is not sufficient to reduce the prevalence of the travelers below that of the destination country. Next, we look at some single test-based strategies. So we start with a single antigen test, 24 hours pre-departure, and then also we've looked at a single RT-PCR test, 72 hours pre-departure. The RT-PCR test is slightly improved performance over the antigen test, but with just a single test, many of the early stage infections can be missed. So for this example, travel journey, even though we are successful at reducing the prevalence below what would happen with a low compliance quarantine, we're not successful at reducing the prevalence below that of this medium prevalence destination country for this example travel scenario. So next we look at some dual testing strategies. So this first strategy that we have highlighted is 2 RT-PCR tests. The first one is given 72 hours pre-departure, and the next test is given 4 days after arrival, with those 4 days spent in quarantine. So you can see here that with that very short quarantine, the performance of this strategy is quite good. The prevalence is much lower than the single testing strategies, and it is able to achieve a reduction in prevalence below that of the destination country. And you can also see that the performance is very close to that of a 14-day quarantine with 100% compliance, but with a much shorter quarantine period. Next, we look at some serial antigen testing based strategies. So the first strategy in the middle of the chart here shows an antigen test 24 hours pre-departure, and then serial antigen testing every other day for 4 days after arrival. So these passengers, after they arrive at their destination, they will receive an antigen test every other day. And the next strategy is similar on the far right of this chart. And this includes an RT-PCR test, 72 hours pre-departure, and then serial antigen testing every day for 4 days after arrival. So these passengers will receive antigen tests every other day. And you can see that these strategies are quite effective. In fact, the daily antigen testing with the pre-departure PCR is the best performing strategy of all these compared here. And it's in fact even better than the 100% compliance for day quarantine based on our model results. And these serial antigen tests can be done without quarantine. There is some risk involved if these passengers are not quarantining, but with regular testing, especially the daily testing, most of the infections are caught very early and with that frequent testing. And so the risk is quite low, even if passengers are not quarantining. However, one thing that I should mention is that one downside of serial antigen testing is that antigen tests have false positive rates that are higher than PCR-based tests. And with many antigen tests comes many opportunities for false positive test results. So the overall false positive rates of these strategies that include many antigen tests can be quite high. So for that reason, we are recommending that positive test results from antigen tests in these serial antigen testing strategies should be followed up with a PCR test to confirm an infection and to avoid possible complications from high false positive rates. So the next steps in our modeling, the ongoing work that we're doing, includes looking at SARS-CoV-2 variants and also COVID-19 vaccinations. So in looking at variants, we have the ability with the appropriate input data that will give us prevalence values for specific variants of concern. We can model the effectiveness of screening strategies for specific variants of concern rather than overall COVID-19 infections, which may be of interest, particularly for travel between countries where the origin country may have a variant of concern that is more problematic than what is at the destination country. So this is one thing that our model can look at. And we also have the ability to change input parameters for different variants that may be better or worse. There could be either condition, but we have the ability to change input parameters to our model to address these variants. In addition, we have also started looking at COVID-19 vaccinations. And in particular, we have looked at screening strategies where vaccinated individuals are either exempt from screening or have a less stringent screening protocol required for vaccinated travelers than for unvaccinated travelers. So in summary, our model provides a way to compare the effectiveness of various testing and screening protocols. And we have shown that there are many options for test-based screening protocols that can often be as effective as quarantines. In addition, we have developed a tool to implement our model that will be useful to air travel industry stakeholders for comparing a wide variety of testing and screening strategies. It's a very flexible tool that allows for many different screening and testing strategies to be compared and for user-defined strategies to be compared as well. Additionally, we've recently published a white paper on the Boeing Confident Travel Initiative website, which describes the modeling work we've done for passenger screening. Thank you very much, and thank you all for this great opportunity, and that's all I have for today. Thank you.
Great. Thank you very much, Lindsey. So just before we take questions, and I'll remind everyone that we'll take questions in the Q&A function. I know there's some flexibility in how you can set up your screens, but normally you should see Q&A on the right-hand side of your screen. If you want to type your questions in there, that would be fantastic. Before we take questions from the audience, though, what I'd like to do is talk to David Heymann for a few moments. And I've got a couple of questions just to get his impressions of what we've presented today. And I should be very clear, Dr. Heymann doesn't work with IATA, with Boeing, or with Airbus. He's a professor at the London School of Tropical Medicine and Hygiene. So, yes, completely independent as an observer. But David, what we'd like to do is ask you a couple of questions. First question is, what you saw here today, do you think that will help governments in understanding how to model risks, and do you think that will help them in their decision making? And secondly, what do you think governments should be doing in order to prepare for a travel restart?
Yeah, well, thanks, Tony, and thanks to all the presenters. You know, watching through these presentations just has confirmed what I have believed all along, in that the experience in the private sector in risk assessment, no matter whether it's industry or in the airline industry or other industries, is really applicable to what we're facing today. And, you know, I chair a group at the World Health Organization, which is the advisory group to Mike Ryan's program, the program that's responding to the COVID outbreak. And early on, in discussions with Mike and our committee, we came to the conclusion that the only way that travel would begin again is when countries perceive equal risk among themselves, or were able somehow to mitigate that risk. And I think the models clearly show two ways that that could be done. And I'm very grateful to have actually been able to listen to them.
Great, thanks very much, David. The models don't talk specifically or address specifically variants or vaccinations, but do you think from what we know now, we can be confident that people who are vaccinated pose a sufficiently low risk in order to be able to travel?
Well, you know, what the models have shown is that it's important for countries to, first of all, determine the threshold of risk that they can accept for international travel, whether people are vaccinated or not. They need to be able to accept that risk. Then once they've accepted a risk, a threshold of risk, then they have to figure out which strategies of testing are feasible. And certainly vaccinated persons will be a bonus. But remember, vaccines are used by travelers to protect themselves. That's how we've always seen people use vaccinations, whether it's for yellow fever or whether it's for polio. It's to protect individuals that vaccines are given. We know that the vaccines today do have an impact on transmission. We don't yet understand the full extent of that decrease, but we do know that some of the vaccinated people can carry virus in their nose, but at a level which probably can't be transmitted. So I think I heard from the modelers from Boeing that they're looking at vaccinations as a means of adding, you know, increased security to travel. And I think that's very important. But remember, vaccines are a personal protection for travel at present, so we better understand their capacity to decrease transmission.
No, without endorsing any one solution or conclusion, I guess, do you think what we've presented today as potential strategies have credibility with governments as a way to get people traveling again?
I certainly think they have the credibility to now discuss with governments a way forward. You know, what's really set off governments is the variants and the fear that they will escape the protection offered by vaccines. So no matter what you show as far as low incidence, there's still going to be concern about the variants, and you're taking that into account in the models as well. So I think it's really extremely important that countries look at these models with the producers of the models when they're making their policies. They talk with their expert groups in the country using these models, but that they also then have the courage to take the risk to do certain of these strategies, but to monitor very closely so that they know what's happening and can make sure that if things are going bad, they can begin to adjust their policies accordingly. So I think, yes, Tony, I think these are incredibly important models that governments should be looking at and should be working with the industry to try to move forward on international travel. Vaccination certificates are another issue, as you know. They can add increased security, especially to passengers, but until there's more equitable distribution of vaccines, I think it would be very difficult for any one country to require that everybody arriving there have a vaccine, although who knows what might happen moving forward. We've seen lots of unusual responses to the current pandemic.
Okay, thanks, David. And last question. Do you think there's hope that we'll get back to something that looks like normal in terms of how we travel?
You know, it's clear. I heard Willie Walsh say that earlier, and it is clear that this disease is now endemic. It's becoming endemic in all countries. Countries will have to face how they're going to let this virus enter their countries. And that includes countries that have locked down and prevented it from coming in. They will try to vaccinate maximum numbers of population, but the virus will likely come into all countries eventually. And population decisions will have to be made. Shall we let one population become infected naturally in a controlled manner, much as is occurring now in many of the Asian countries where cases are coming in a controlled manner? But the one caveat is this misunderstanding of long COVID. We just don't understand what happens when people get infected and develop immunity, whether or not that long COVID is going to continue. We know that there are other viral infections, such as mononucleosis, which have long sequelae afterwards as well, including continued fatigue for up to 6 or 7 months. So what we need to do is sort that out before I think governments will really be content to say, well, the young people are not at great risk of serious illness and infection, and we can therefore let them in a controlled manner become infected over time.
Thanks, David. We've got some questions starting in the queue. So again, I would encourage people to type their questions into the Q&A section on the right-hand side. I know we've given out a lot for people to think about. I'll remind people that we will have a release on this distributed just as this press conference ends. And we'll also have some more information on our website, and you'll be able to reference back to the discussion and the presentations on our website. If I could ask our presenters to turn their cameras on so that we're ready to respond to the questions. And we'll move to the first question. And I guess just as a preface to say, this particular press briefing is not about proposing any single model. It's about trying to demonstrate that data can drive decisions which we believe should and can facilitate a reopening of travel. So with that, we have a first question which references the Boeing model. And it asks, how does the Boeing model allow screening for variants of concern, given this requires PCR testing and subsequent sequencing? So, Lindsey, did you want to speak to that for a second?
Yes, we're currently not addressing variants of concern. We are using input data from the Johns Hopkins database to estimate prevalence in any country. So that is overall COVID-19 prevalence rather than prevalence of any specific variant. However, we had a data source that gave us prevalence for a specific variant, we would be able to use those prevalence values in our model. So yes, I completely agree. Sequencing is necessary to identify variants. So we would rely on the appropriate input data in order to model that. So right now, we're just looking at overall COVID-19 prevalence.
Thanks very much, Lindsey. That's clear. Now, we have a question that's got several parts to it. So the first part of the question says, these presentations seem to indicate different solutions potentially for different countries. And I guess the first question maybe to you, Willie, would be, are you concerned that that could create confusion and perhaps discourage travel rather than encourage travel?
Ideally, we'd like a common position adopted across the world, but I think that's unrealistic given what I said in my opening remarks, that we're in different phases of this response in different parts of the world. The one thing I would say about the airline industry is we already have different entry requirements. If you consider countries today where you need visas to enter, depending on where you're from, in some cases there are restrictions on how much validity is left on your passport. So it's not a simple one-size-fits-all approach today or prior to COVID, and it certainly won't be going forward. The good news is that IATA can help with this because we have a database called Thematic, which is used by airlines and airports, and indeed increasingly by being used by other sources, that contains all of these entry requirements. So it will become easier for people to understand. And also, I would say the good news is that the IATA travel pass will help people, because it will tell them what the requirements for travel are in advance of their decision to travel. But more importantly, what we see is that people want to travel. There's huge pent-up demand. And the idea that we keep everywhere closed until everyone can agree on a criteria that should apply, I think would be unfair. And we're already seeing that countries have decided to go their own way, to reopen their borders, because they assess the risk to their people as being low or extremely low, and they're prepared to operate in an environment where they will tolerate that risk and put appropriate mitigation measures in place to restrict any unnecessary risk.
Okay, thanks very much. The second part of the question references the fact that many of these strategies require testing, and testing has costs associated with that. So probably, I know this really is an issue that's dear to your heart. Are you concerned that the cost of testing could in fact discourage travel?
We're certainly concerned that the evidence we have suggests that people are charging excessive amounts. There's profiteering in place with regard to PCR testing. And I think the presentations demonstrate that much cheaper, more convenient rapid antigen testing can be effective and can be used in an effective way, again, to mitigate the risk. So what we're calling for is a sensible approach to testing. What is clearly unacceptable is where countries have introduced these testing requirements because of health concerns. And again, I would point to the UK, who are actually using all of the data, that 370,000 people that I commented on earlier. Those people are paying for the tests that is then providing the data to the UK to make decisions. And what is really unacceptable is that the UK government is charging VAT on top of the exorbitant cost of PCR testing. So if this is genuinely a health concern, well then testing should be provided free, as suggested by the WHO, or should be provided in an environment where costs are controlled, or where we can use convenient, low-cost testing methods to ensure that the risk is being monitored and mitigated properly.
Okay, thanks, Willie. David, I know you had some thoughts on testing and the use of PCR and antigen, et cetera. Is there anything you wanted to add to that?
No, I would just follow with what Willie said. You know, PCR is a very expensive test in most countries, and there need to be other means of doing it. But I would just add one observation in that it's a trust issue, because people are expected to do their own nasal swabbing, which isn't very pleasant, as many of you know. And so they're doing their own nasal swabbing and their own throat swabbing in order that they can, in fact, then... Are you hearing me?
Yeah, that's a bit better if you're closer.
Yeah, okay. And so people are using, the governments are believing that people are doing the swabbing, but they may not be doing it or may not be doing it accurately. So again, false security would be very difficult to accept, that people are doing the test all the time the right way when probably they're not.
Okay, thank you very much. So we have a question about the distribution of vaccines. The question is, do you think it's beneficial for global health, air transport, and the economy in general to have a more even distribution of vaccines? Maybe, Willie, do you want to take that one first?
Yes, I think there is a requirement to ensure that vaccines are distributed to parts of the world where they have not been able to afford to vaccinate their population. And we would support the calls for sharing of vaccines to ensure that the maximum number of people globally can be vaccinated. And we certainly could not tolerate a situation where vaccination is only possible in rich economies, in rich countries. Many of the countries that are suffering most from the lack of international travel depend heavily on tourism for their GDP. They're the ones that are suffering most, and it's a downward spiral for them because their GDP, local economies have been severely restricted and they cannot afford to vaccinate their people. So yes, I think a global system to ensure that as many people as possible are vaccinated would clearly be a positive development.
Okay. David, I see you nodding. Is there something you wanted to add to that, or?
No, I would add that, yes, it's very important that there be equitable distribution of vaccines. We've done it for polio, we've done it for childhood immunizations, we've done it for many other immunizations, and we need to now do it for COVID-19. But even more importantly for COVID-19, we know that in countries where there's uncontrolled transmission is where the variants are more likely to develop because of the mistakes that are made in this massive reproduction of virus. And so we need to look at this as a security issue as well as one which will make safe travel.
Okay, thank you very much. We have a question about how this discussion is moving with governments. So on the one hand, for Boeing and Airbus, how are you using these models? Who are you talking to? And what has the reception been? So maybe we'll start with Lindsey and then Elisabeth.
Sure. Yes, we have done quite a bit of outreach. We have spoken with air travel industry stakeholders and governments and other policymakers or people with an interest in this issue. And we've had a really great reception, a lot of interest, and we've had repeat engagements with several groups and interest in looking at tailored scenarios for specific travel situations or for specific countries using our tool.
Okay, and Elisabeth, have you
Yes.
or Boeing or Airbus?
Thank you for the question. Yes, we have shown the model with some aviation authorities, some with authorities, transport ministry. We have also worked with aviation stakeholders, showing the model. Now, to really use the model, we needed to have more data because we adopt a conservative approach to really validate what we are showing with actual data, and that took time. This is now the time. So we want to engage further cooperation with the health authorities and with governments in order to progress the tool, to make it evolve. As I said, this is an evolutive model. What you have shown today, it is taken the today knowledge, but this will evolve, and then we are going on this topic.
Okay.
But already we could demonstrate that even not taking into account all the news, the new progress concerning diseases like vaccine and so on, there are ways to mitigate the risk without asking dual testing or whatever, depending on the pandemic situation, like I've shown from Europe to the US, where just an antigen test would be enough if US governments decide that their level of threshold of risk is higher than what I've shown, for instance. But this is a decision to be made by authorities.
Okay. And Willie, I know you've had been pushing the message with governments to try and do database or data-driven decisions. What's the reception been like? Are you optimistic that this idea will catch on?
Yes, I am optimistic. It's clearly not going to be adopted by everybody, but more and more I think governments are recognizing that the situation is changing, and they recognize that the policies that they've had in place will need to be amended. So the IATA teams regionally have been reaching out to politicians right across the world, and I've personally spoken to a number to outline the need to have a data-driven approach to address the concerns and ensure that we can manage the risk as best as possible while recognizing that zero risk is not a credible option.
Okay. And there's a follow-up theme in a couple of the questions, which is asking, do you see particular parts of the world leading in that discussion or particular countries moving forward more quickly?
I would certainly highlight Greece. And as we all know, tourism is an important contributor to the economy of Greece, but they have already taken measures to open up their borders to allow people to travel in. And they're taking a very scientific approach in addition, using artificial intelligence to monitor the risk and to point them to areas where they should be paying attention rather than looking at a single approach to all countries or all people who want to enter Greece. So we are seeing evidence of countries now recognizing that risk can be managed using science, using data, using artificial intelligence. And we're seeing more and more countries questioning whether they have the appropriate measures in place today.
Okay. And then maybe, David, from your perspective, how would you see this dialogue developing with governments? How can we bring this to the public health authorities? Is there a framework that you might see this happening in?
Well, I think there's been a lack of private sector input into government decisions during this pandemic. Governments, and there's also been, in many instances, a lack of public health input into the discussions, which have become, in many ways, political. So I think that moving forward, it's very important for the private sector to have a voice with the government, not a lobby voice, but a voice of reason with the modeling groups that are working within countries and with other groups in like-minded countries. I think we saw the attempt of Singapore and Hong Kong back in December to open up travel, and there were problems at that point in time. So I think there are ways that the private sector needs to be working with government and needs to have a voice and help move things forward.
Okay, thank you. We have a rather technical question about the importance of sequencing. And I think perhaps on the technical side, we can try and get back a bit later. But I suppose the question, really, the essence of the question is, how important is it to do sequencing? How important is the variant discussion to the overall drive towards data-driven decisions and eventually getting borders open? So maybe, David, you're probably the most qualified on the medical side. Do you want to start us off in addressing that?
Yeah, thanks, Tony. We've seen that sequencing is important in other infections. Polio, for example. With sequencing, you can tell where a virus has come from, where it's traveled to, a whole series of different fingerprinting activities, which are very important. The same with tuberculosis. And we've also seen it with influenza, which is a disease that's a respiratory disease, as you know, in many ways similar to COVID. And so that is a sequencing network which is taking specimens from people who have influenza-like illness and seeing in a random sample of them what the sequences might be and where the variations might be. A similar system is being discussed for COVID-19, and it will be very important. What we've seen now is that countries, especially the UK, which had an excellent network of sequencing already going on, they're able to detect the variants very early. We've seen that South Africa has done the same, and now we see other countries building their capacity to do this. What we have to remember is that there were probably variants previously as well, and now we're able to identify them better. And we need to keep doing that, because once you get a variant, then you need to see whether natural protection from an infection causes a neutralization in the laboratory of that virus. And also you have to do the same thing with people who have been vaccinated to see if their blood, their serum, and the antibodies in that serum neutralize the virus in order to see whether the vaccine is still effective. So yes, it's very important to do sequencing. Sequencing should be done in a routine way so that all countries are participating. And there's a drive now to get new technologies, which are handheld sequencers, into developing countries where they can be used and where they can contribute much better than they have been able to in the past.
Willie, we have a slightly more general question, which just asks, how do you assess the prospects of the industry if international travel is not able to restart more significantly in the near term?
Well, the first thing I would say is I'm confident that international travel will restart because the data that we have available to us and the improvement in modeling that we've demonstrated today points to governments being able to reduce, remove, or adapt the restrictions that they have in place to facilitate international travel. And just going back to the previous question, I think some people are missing the point that, what we have now is data that shows, for example, in the UK, that of the 108,000 people that flew in from red-listed countries considered high risk and are forced at their expense into hotel quarantine, less than 4% of those tested positive. 96% of people who were in effect locked up for 2 weeks at their own expense, there was nothing wrong with them. And these were people traveling from a high-risk country. So there's plenty of evidence now to support that borders can be opened in a sensible way. Certainly clear scientific evidence that vaccination helps to not just protect the individual who's vaccinated, but is suppressing the transmission of the disease. And with sensible testing and screening methods in place, we can safely open our borders to regain the freedom that has been taken from us. So I am confident that we will see international travel resume, and I'm confident that we will see a much better second half of this year than we've seen in the first half of 2021.
Great, thank you, Willie. We have the question for Dr. Heymann again. And this is just, I guess, to make clear your role here today. So the question has two parts. One part of it is, can you confirm that you're not being funded by the industry or by IATA or by anybody else in your participation in this or in any of your other work? And I guess the second part of the question is, and we've tried to make this clear, that you're not endorsing any of the specific models, but only the discussion. But perhaps, David, in your own words, you could explain that.
Yes, I actually agreed to participate in this conference because I feel it's very important that some order come into the decisions that are being made about travel. And I'm not paid by anyone associated with this press conference or with anyone else except the London School of Hygiene and Tropical Medicine and Chatham House in London, where I do some research. If I do get an honorarium at any time, I provide that to charity, but I haven't received and haven't asked for an honorarium for this discussion. So that's the first part of the question. The second part of the question is that I don't endorse any models. I endorse only the fact that these are being done and that these are showing one view, and they need to be speaking now with modelers in countries who are also modeling and who also have ideas, and try to come to a technical agreement between modelers. It is not in any way useful to have these models be used to lobby governments. It's much more important that they be used to open up discussions, technical discussions with persons within countries.
David, I think that's very, very clear. Thank you very much. So we have a couple of other questions that are here. So I guess one of the questions would be, how do we've been talking a little bit about vaccinated passengers. We have people who are vaccinated with certain vaccines. Some vaccines are recognized by certain countries. How do you see eventually this system where we have some vaccines that are recognized, some vaccines that are not recognized? How do we bring order and certainty to travelers so that, in fact, their vaccinated status can eventually open up borders? Maybe, Willie, did you want to start first?
Yes, what we've said is, again, we should turn to the WHO, who are the experts in this area and who will make decisions on the inclusion of vaccines based on data. And that's exactly what they're doing. I saw a press release earlier today saying that the Sinovac has been added to their emergency use. So, I think we should look to the experts, look to the most credible source of data and take the lead from them.
David, I know you've got lots of connections into the WHO and their thinking. Is there anything you want to add to that?
I don't think I can add anything more than to what Willie said. There are vaccines that have emergency use licenses from the World Health Organization. And if people want to be sure that they have a vaccine which has gone through a rigorous control globally with representation from 6 different regions of WHO in the decision making, then they should consult the WHO website. And if their country is not using that vaccine, they might then want to check with the regulatory agency in their own country to find out the licensing information in the country. And they might even want to question why it's not yet been submitted to WHO for a license.
Great, thank you. There are a couple of questions about the models. They're clearly very complex. They've got lots of data sources. And there are a couple of questions asking essentially, how do you keep them up to date, given the dynamic situation out there? So maybe Elisabeth, did you want to go first? And then we'll turn to Lindsey for her comments.
Yes, sure. So our model, in fact, is using not only the aircraft safety modeling aspect, but as I said, our knowledge in handling big data. So we have tools inside Airbus which are able to access databases where the national epidemiological data are updated on a daily basis. So we are getting on a daily basis those official data thanks to the IT capability that we have. And this is what you've seen in the tool. This is updated on a daily basis, in fact. So this is thanks to the progress of IT now that we are able, with the cloud and big data, able to access database with national official data, in fact.
Lindsey, is there anything you wanted to add to that?
Yes, what we're doing is very similar to what Elisabeth described. We also are updating the prevalence data daily that is pulled in from the Johns Hopkins University COVID-19 database. And we get daily updates. That database is updated daily, and we pull daily updates into our tool. So we are using current up-to-date prevalence values for our model as well. And with respect to the vaccination rates, I know there was a question about data for vaccination rates in the models. We are primarily at this point using the prevalence data, so the vaccination rates will affect the prevalence data from a country, but there are some databases that have sources for percentages of population that have been vaccinated in different countries as well. That can be used in the future to compare strategies for where strategies differ for vaccinated and unvaccinated travelers.
Okay, great, thank you. We'll change tact a little bit. There's a question that talks about testing and again, the cost of testing. And one part of that we didn't address earlier was who should really be paying for those tests? Willie, I know you have some ideas on that.
Yes, I believe where the testing is being mandated by governments, well, then they should be funded by governments. I believe that's the recommendation of the WHO. The research that we did in relation to PCR testing showed that France is following that model. It was the only country that we could identify that was following that model. If you have a system where people can do rapid antigen or serial antigen testing, then I think you could make a case that the individual should bear that cost. But today, where it's being done on the basis of mandated PCR testing, which, as we've said before, is expensive and clearly very expensive for the end user, much more expensive than the actual cost of the testing, then I think we have to question why the costs are as high as they are, and why, in many cases, governments are charging VAT on those tests as well.
Okay, thank you very much. We have a question referencing the IATA travel pass, and the questioner is asking in reference to Russian vaccines, but I suppose more generally, the parameters for the IATA travel pass, Willie, are they open to all government-approved certifications, or are there limits on what we're able to deal with?
It's a great question. The issue is the travel pass will assess the entry requirements for the customer traveling internationally. So the database will be checked against what the country requires of the customer. Now, some countries may decide that they're not accepting certain vaccines, and therefore, if the individual customer has evidence that they took a vaccine that's not approved, well, then they won't get access to the country as a vaccinated traveller. They would therefore have to comply with the testing requirements for an unvaccinated customer. So the database is capable of taking feeds from any reliable source, but it will in effect determine what the entry requirements are. And if the customer can't demonstrate to the satisfaction of the country that they're traveling to that they meet all of those entry requirements, then they either won't be able to travel or they'll have to travel as an unvaccinated or non-vaccinated customer.
Great, thank you very much. We have another question that talks about the in-flight experience. And it's basically saying, right now we've got strong recommendations, in some cases mandates, that customers wear masks on board. But how do we deal in situations where customers, for health reasons, for example, are not able to wear a mask?
Well, where a customer is traveling and can't wear a mask, there already is a system in place where they can provide evidence, normally given by their physician, their doctor, that will show that they're exempt from wearing a mask. So, you know, we're well able to deal with these issues. We deal with these issues on a regular basis. And to be honest, it hasn't been an area of concern. And what we're seeing globally is that there's very, very high rates of compliance with the requirements to wear masks. You know, we do have, and there have been documented incidents where customers haven't done so. But, you know, that is easy for the airlines to manage in the same way as we manage unruly customers that existed prior to this coronavirus outbreak. But the levels of compliance that we've seen have been extremely high. And I think that recognises that people who are travelling genuinely want to travel and will do what's necessary to be able to exercise the freedom that they've enjoyed to travel as they did before this virus outbreak.
Thank you for that. David, did you have anything you wanted to add on mask wearing? No?
No, I think it's important just to remember that wearing a mask is to protect others. And it's really our duty to do this when we are traveling with other people, if we can wear a mask, to wear a mask. And if we can't, then we have to make sure that we try to compensate for that by avoiding speaking directly to people who might be at risk of getting infected, and make sure that we travel in the right way so that we don't put others at risk.
Great. Thank you for that. Willie, I think this question is probably for you. And the question is, Green Pass will be useful.
Yes, I think anything that shows that countries have adopted a common standard. So if the EU could adopt a common standard, it certainly would be helpful. What we've seen in relation to testing requirements, for example, in the EU is, I think, 15 different requirements by governments within the EU 27. So some require PCR testing within 24 hours of travel, others it's 48, others it's 72. Some require all passengers from newborn babies up to be tested. Others have, you know, minimum ages varying from 3 to 18 years. This causes confusion. It's not impossible for us to deal with this, but it can be embarrassing for the customer who believes that they have complied with the entry requirements only to discover when they get to the airport that they haven't. So a common standard within the EU, which you know, should be possible, would be a positive development, and we would have to encourage people to adopt a single standard where possible, or to have a system where they will mutually recognise the standards that have been applied in other countries.
Okay, thank you for that. We have a couple last questions in the queue. We've got 9 minutes left in the scheduled time for this event. So if anyone has further questions, please get them in quickly. Otherwise, we've got two final questions here waiting in the queue. First one is for Willie. It says vaccination rates across Europe suggest a majority of adults will be fully vaccinated by the autumn. How confident are you that there will be a substantial reopening for July and August? And what would be the implication if that was delayed into the autumn period?
Yes, we're already seeing more and more governments come out and state that they will allow vaccinated customers to travel without restriction, which I think is a very positive development. And I think, again, it's important to remember that, our freedoms were removed from us or were restricted because of a clear concern that existed 15 months ago when this virus was first identified, that there was a risk that health systems would be overrun. The environment in which we're operating today is very different. We now know that vaccinations are effective. We know that testing has significantly improved. We know that the medical treatment for people who have contracted the virus has also improved. So, I think for governments to continue to lock their borders, they need to provide a strong justification why something as important as your freedom to travel has been removed from you. And what we're seeing is, public support, which has been strong for governments, is changing as evidence of widespread vaccinations become available. Because in many cases, we were promised that we would regain our freedom once vaccinations were available. And now where there is evidence of widespread vaccination, I think there is a generally accepted and maybe a generally demanded situation that these restrictions be reversed. So again, I am optimistic about the second half of this year, particularly in Europe. I think all of the evidence and the data supports that governments can reduce or remove the restrictions that they put in place to protect everybody from a collapse in the health system. That clearly was real 12, 15 months ago, but that risk is significantly reduced today. And in many cases, we're seeing the evidence of transmission, of hospitalization, and tragically, still seeing deaths, but those figures are all going in the right direction.
Okay, thank you. One question on the vaccine issue, and maybe this is for David, but do you see vaccination, and particularly the acceptance of vaccinated passengers, as perhaps a tool that governments can use to encourage populations to get vaccinated? I mean, how important is it to have those incentives in place?
Yeah, certainly there is an incentive if a government decides that you can't enter a public space or you can't get on an airplane without a vaccination. But I think that until there's an equitable distribution of vaccine, it would be very unfair for governments to require vaccination of people traveling. And as I said, vaccination is an individual protective measure, so people need to do their own risk assessment. And coming back to what Willie said earlier, governments took away from people the ability to do their own risk assessment and response. And they didn't give them all of the tools they need to really be doing that today. And so we see as people become free from lockdowns, they sometimes do risky behavior that really they need to be modifying. But they've been disempowered by governments forcing this upon them in some instances. And it's a hard shift back to personal responsibility to take that on and do it. But populations are doing it, and it's very important. And it's also important to remember that variant strains are a fear, but variant strains only transmit if people have the behavior that permits them to transmit, and their transmission rate is based on the immunity in the population into which they've entered. So it's not just a virus that's important, it's the whole issue of getting people to do their own risk assessment and respond appropriately, whether it's on an airplane or before airplane travel or just in general.
Great. Great, thank you for that. And then I think we have time for one last question. And that question, I suppose, goes to Willie. It says, what exactly would IATA like to see come out of the G7 summit? Are you expecting a decision, a resolution, an endorsement, or just a mention? And obviously, what would be the substance of what we'd like to get out of it?
Well, I think what we would like to see is that the issue is being discussed, and I would be surprised if the leaders of the G7 cannot conclude that making decisions based on data is the right way forward. I think David made the point there. Governments have removed from us our ability to assess our own appetite for risk, because they've said, they will do that for us. If they were to do that for every risk that is known to man, I can't see how we would live in an environment like this. So we have got to get back to a situation where governments make decisions based on data. Individuals are provided with the data, quality data, that then enables them to decide what level of risk are they prepared to take. Because not everybody will have the same risk appetite, but they can only assess that if they're being given adequate, accurate, and detailed information to enable them to do so. And we would expect that the G7 would agree that we should take a data-driven approach, as the G20 did when they met.
Great. And with that, we're almost at the 30-minute mark. So that will be the last question. I would thank all of the panelists for their excellent contributions today.